Well, thanks so much for having me. It's really nice to get to share what I'm working on. So with my close collaborators under Nigam Shah at the Department of Data Science and with my close collaborator, Michelle Mello, we've been tasked with coming up with an approach to evaluating AI tools being considered for deployment across Stanford healthcare. And because Stanford's vanguard, it's having national resonance, the work we're doing here. So I want to talk about the ethics work. Let me share my slides. It has been said that ethicists are not great storytellers, usually by undergrads assigned to take their moral philosophy survey course. And that's a shame because ethicists have a story to tell. They just tell it in values, principles, categorical imperatives. Have you ever read Kant? They're not great storytellers. But there's a story emerging that I think is important for us all to weigh in on. Because if it hasn't impacted you yet, it will. And it starts with a question I'm increasingly getting asked, which is, should AI replace doctors or nurses or healthcare professionals? And it turns out that's not, or increasingly, not such an easy question to answer. So this is the Sedasys machine. It's from a hybrid of my field and yours. It's a tool introduced by J&J and pulled off the market in 2016. So it's an old technology to do targeted sedation for endoscopy. They got FDA approval for it, and it worked. It used some vital sign feedback as well as a grip tester to see the depth of sedation and provide sedation while somebody was doing endoscopy. And they pulled it off the market not because it didn't work or because there were safety concerns, but because they couldn't fiscally fit it into workflows in such a manner as to make it profitable, which is to say, just introducing it didn't lead to hospitals wanting to reduce the number of anesthesiologists, or they didn't figure out how to improve or expand endoscopy workflows to make this thing viable. But the world has changed a little bit, right? Healthcare workflows are human entities, largely because we've had human labor constructing the workflows that we exist in. And where we've introduced technology so far, it's been to enhance human tasks, right? So we have seen since Sedasys an explosion of things like in my field, ultrasound-guided peripheral IV placement, which clearly makes it much, much better. I and my colleagues notice and comment all the time that when I was starting in pediatrics, it was a very arduous task to learn how to place IVs in neonates. Now with ultrasound, it still has its challenges, but it's much, much easier to do, dramatically so. Similarly, laryngoscopy in my field, right? There was a lot of airway expertise, and there still is some requirement, but clearly the advent of video laryngoscopy has allowed a lot of non-physician providers to become quite adept at airway placement. So introducing both of those into a workflow would suggest that you could allow non-clinician or not as skilled clinician providers to take on potentially more significant roles in a workflow involving sedation. The world has changed too because we have a shortage now of providers. Your field and mine, post-COVID, we had a large atrophy in clinicians. The senior generation, many of them took early retirement, and that's led to a significant shortage in providers. And now with the uptick in procedures, this data from England demonstrating just the number of backlog endoscopies that we still have and how to figure out how to attack them. So you could envision that we could reconfigure a workflow to optimize use of non-human technology labor, as well as enhancing quite as skilled clinician labor to reconfigure how we do what we do and potentially save significant costs. It's hard to show that it's in fact better because once you start altering the workflow, you're comparing apples to oranges, right? So you can look at outcomes, but there are questions about many of the studies focus on non-inferiority, simply showing that it's not worse. In England, where they have this shortage, there is, in my field, a push for these high-intensity operating theater lists, where they're taking specialty interventions like endoscopy, or this from a urology journal, where they put multiple ORs in parallel and have clinicians bounce back and forth and have exactly what we've described, not quite as skilled clinicians teeing up the patients so that the clinician labor can then bounce back and forth, and they can go through a large number of patients in a short period of time without demonstrating a worsening of their outcomes. So this is becoming increasingly what we're looking at with Nigam. This is our multifaceted team that's part of what we're calling FIRM, the Fairness Evaluation Metric, to look at AI tools being considered across healthcare systems, particularly our healthcare system. But you could envision that what we're looking at is components of cost, whether the algorithm actually does what it's supposed to do, does it work, as well as ethical and social implications of it. But increasingly, that role is having to consider, too, how the workflow within healthcare is altered. And it leads to some significant ethical questions. Is non-inferior good enough? Just because we can, should we? Are cost savings alone an appropriate reason to drive AI implementation? While AI struggles to cross the chasm and demonstrate clinical utility, its main use and main driver has been that it replaces expensive labor or expensive to do tasks. Is that enough? And what do we do about skilled labor that's potentially repurposed or displaced by AI? So what I want to talk about today is the methodology we're working on to come up with these questions, as well as come up with answers for these questions. Because my field, of which I am one, but of this generation of empirical ethicists, of trying to come up with evidence to support ethical policy decisions, is still nascent and is still developing methodologies that convince the unconvinced. So I have to talk a little bit about the context and the changing context of ethics in healthcare and the world into which AI is being introduced. We're in something of a sea change in medical ethics. When I was in medical school, and probably when you were too, ethics was very much framed as a dyadic relationship. So the relationship between a clinician and a patient and a clinician, or a researcher and a patient and a researcher. But that's increasingly not the world in which we practice anymore. Increasingly, we're part of a complex social network that is becoming known as the learning health system, in which data is both captured and multidisciplinary providers unite to provide care. And that's led to some changes in how we consider ethical issues. And we've known it, we've seen it coming for some time. So this is Mark Ziegler's 40-year-old paper about the challenges of maintaining confidentiality in medicine and the rise of HMOs, right? And that's only gotten worse. It's very, very hard for us now to actually provide true privacy in the physician-patient relationship. And some would ask as to whether that's a good thing as we have more and more supernumerary analysis of what we're doing to provide benefits, right? Predictive analytic tools, other specialties that can read in on the note that you're doing and weigh in whether withholding the benefits to protect privacy is in fact useful, is a debate. This is Chiara Lapura's work on complicity. Chiara was until recently with Doctors Without Borders. Now she's with WHO in Jerusalem. But from her work with Doctors Without Borders, she talked about, in many contexts, Doctors Without Borders was deployed into militarily controlled areas, right? So they had to go through or work with the junta that controlled the area they were in to get access to patient populations to treat. And in many ways, the juntas would dictate what care they could give. You can treat this village, but not that village. You can help these soldiers, but not those soldiers. And she asked a lot of salient questions about at what point does working with these military dictatorships become complicity? And when is it compromise? And when should WHO not deploy? And when should they deploy? That's not to say that we're all complicit in working with a junta, but it has relevance and resonance for what we do. So this is Doug White and Bernie Lowe's paper during the pandemic, talking about how a bedside clinician would make decisions regarding rationing ventilators for the COVID pandemic. And that's important work, right? It's difficult for a bedside clinician to make a discerning decision about who gets or doesn't get a ventilator. But it's also the tip of the spear. The bedside clinician is only in that position because of augmentations to the supply chain of how we get ventilators and the number of ventilators we have. When I was in my clinical training at a small medical school just up the road called UCSF, there was a large warehouse space where we stored old ventilators. And several times during my residency, I had to go down, make workable, and calculate out doing old-fashioned ventilatory anesthetics, particularly a copper kettle anesthetic, where you had to titrate in the amount of volatile anesthetic. But the point was they had a number of archaic but still usable ventilators that could be made workable and that clinicians still knew how to use. That doesn't exist anymore. In our supply chain economics, that just nobody has spaces like that and houses spaces like that. And that's a decision. I was looking for this as a joke. It has resonance in healthcare. I was talking about the idea of monetizing fire stations. it turns out that's actually a real thing. Who knew? Private equity is actually looking to monetize fire stations, but they have the same problem, which is the punctuated equilibrium of it, which is that fire stations treat individual disasters, and that's the majority of their work, but they also have to be prepared to handle much more complex situations on short notice. And that supply chain winds up being very difficult to fit into modern, just-in-time, profit-focused supply chains. This is very similar to what we've encountered building hospitals in California and what the group that just finished building our new hospital would talk about. It's very expensive to build our hospital. It's very hard to adapt it rapidly. And so there's a lot of anticipatory work to be able to absorb a broad spectrum of potential we have to consider when we design the workspaces that we live and work in. There's also been a change in healthcare labor. So this is Jerry Dew's off-cited paper from 2018 that is a little inflammatory. And what Jerry was pointing out was the rise in the decade from 2005 to 2015 of non-clinical healthcare workers and the degree to which they're increasingly comprising the healthcare workforce. And also the amount to which these non-clinical workers are paid relative to clinical workers without an increase in the number of patients seen. And that's not to say that there aren't a number of managerial and regulatory problems that require this non-clinical workforce, but it's to say that there's a growing stakeholder group that has a considerable amount of power in the workplace that we're part of, that while often they align with us, the motives of driving profit in medicine and caring for patients are often in parallel, but sometimes perpendicular. And those value collisions can be important, right? We've seen a change in the healthcare labor workforce. This is Desai's paper from the New England Journal talking about the many benefits of the 80-hour work week for our trainees. And there are a lot of benefits. Universally, their lives are better than they were in the pre-80-hour work week. But that changes how we care for patients and who is caring for patients and ownership of a particular patient when they come in through the door. And we've seen that in more recent fields. So emergency medicine, in fact, has a more recent field in healthcare, has policies around circadian rhythms and setting up shifts. My own field of anesthesia is very shift-based in how it delivers care. And anecdotally, I'm watching as many of the colleagues I work with across the drape, fields like transplant medicine, transplant surgery, and pediatric surgery, are also moving on to day off, day on models. And that changes how we provide care, particularly when you add to the mix this increasing shortage of providers that are available to deliver healthcare. So increasingly, ethics in healthcare is becoming the focus of so-called wicked problems, which, as opposed to tame problems, which allow for easy formulation, wicked problems involve complex interrelated social networks, and the outcomes are less right or wrong or true or false, so much as better or worse. So if I have 2 points to make about empiric ethics, one is we don't have a tome anymore or a cadre of right thought that we can appeal to solve our ethical problems. But we're also at a tipping point where we're now having to consider new ways to generate evidence that convince people how we can ascertain what the right thing to do is, particularly as we introduce novel technologies. Okay, so let's talk about the ethics of healthcare AI. My path into healthcare AI ethics was a little circuitous. My K award had to do with implementing genomic sequencing into the care of critically ill kids. And what we found in our interview work was a little unexpected, which was the largest anticipated use of AI tools was like this, of AI, I apologize, of genomic sequencing was as described by this neonatologist, which is we could have that discussion earlier with parents and change our goals of care to comfort as opposed to prolongation with futile intensive care, which is if you could identify early on variants that could be consequential, it would allow clinicians to prevent the amount of suffering available. But it also raises a question of self-fulfilling prophecies, and that's something to which any large data extraction and predictive analytic field would be vulnerable. I'm not the first person to talk about self-fulfilling prophecies. This is Dominic Wilkinson, who's a neonatologist at the Oxford Hospitals and a bioethicist. But he talks about how unconsciously or consciously, and particularly he was talking about things like traumatic brain injury or extreme prematurity, that when we encounter clinicians that we know or consider to be fatal or have very dire outcomes, we consciously or unconsciously tailor our care such that those are the outcomes that we encounter. so that we don't allow for space to begin to change how we provide care, right? The self-fulfilling prophecy, predictive analytics from AI tools, they don't notice that the bacteria aren't growing next to the bread mold in the agar, right? So those breakthrough discoveries are more challenging with this kind of the future predicted yesterday type of tools. I approached Nigam Shah, who is now a considerable bioinformaticist here, but at the time was working on this problem called the green button, which is a great problem. And he also was struggling with a self-fulfilling prophecy. The great button, I love this project. And the idea is as we have bigger and bigger data sets that we can capture, if you have a patient and you're at their bedside and you're trying to figure out what to do, you can extract from our data and come up with basically a case series of what other clinicians have done in similar contexts. So you put in all the variables and you push the green button and it comes up with like patients so you can see how care has gone. The challenge is, and it's true for rare outcomes, it's unlikely to be consequential, but it's possible. How many times do you push the green button and follow what you see before it starts self-iterating? Which is to say, you stop doing something novel and you start just doing what you've seen come before and then following it. And that's a challenging question. We wrote it up and said, look, we think there are possibilities that there could be some ethical considerations with AI as we begin to introduce it to healthcare. That paper was largely dismissed. Maybe there'll be problems, maybe they won't. And then in short order, there were a number of very public scandals involving algorithmic tools, the Volkswagen emissions scandal, the Uber Greywall scandal, and Cambridge, Facebook Cambridge Analytica. And people began to say, whoa, wait a minute, there is likely to be considerable problems. And in fact, healthcare may be very vulnerable to them. So let's talk a little bit about healthcare. Biodata is very, very valuable, right? This is the Director of National Intelligence's report from 4 years ago, talking about the amassing of biodata by China, and that the majority of Americans now have elements of their biodata held in China and held by the Chinese government. We've also seen multinational corporations publicly talk about, in many public forums, how to monetize people's individual bioinformation or biodata. That's not to call out either other nation states or multinational corporations, but just to say that key actors in the pursuit of healthcare AI don't necessarily reflexively adhere to Athenian ethics, at least not as filtered through the British and American centuries. So what does that look like? So if you take something like privacy, we've already seen other nation states view what many Americans would view as violations of their privacy as fundamental to state security. Or multinational corporations view as what many Americans did view as violations of their privacy as fundamental to their business model, or what I think we're going to increasingly see in healthcare as fundamental to the transaction by which we purchase their goods and services, which is to say, we give up some element of privacy in exchange for being able to use their tools and their data. And I want to come back to that in a second. If you take an issue like bias, we talk a lot about a priori groups, and I want to touch on that. But if you are building an algorithm that is designed on a Han Chinese data set for exclusive use in a Han Chinese population, the issues of bias and vulnerable populations are going to be very different than if you're building a tool for use in sub-Saharan Africa, where the legacy of colonialism may be informed by some of the scholarship in Europe and America about bias, but also has a series of vulnerable groups and social pressures that are unique to their own context, and elucidating them are going to be challenging and fundamental to identifying bias for these tools. So this is a slide from the EPA looking at fossil fuel emissions by different vehicular markets. In the same way, so one of the challenges with ethics that's uncomfortable to admit is that it is political and that it is regional. And so in many ways, in the same way that vehicles had to be tuned to their local emission standard markets that they were being sold in, we're going to have to tune or at least make explicit the principles around which different AI tools are being tuned or where they're vulnerable as they get deployed globally. Okay, so what are the principles we should tune AI around? This is Alka Patel's work through the Department of Defense. She did spectacular work going around many institutions in America and Britain, including our own, and holding town halls to talk about what were the key principles. There have been many, many frameworks put forward about what we should think about with AI. But they coalesced around these 5 areas. that AI should be responsible, that humans should exercise the judgment, that they should be equitable, that they should avoid unintended bias and harm, that they be traceable, that it be transparent and auditable, that it be reliable and safety tested across its entire domain of use, and that it be governable, that people should be able to turn them off. As an aside, just in the near term, I do think that responsibility is likely to be the one we need to be most worried about. Like many things with AI in healthcare, we're still extrapolating from non-healthcare contexts. So there are a number of narratives about what is going wrong at Boeing or what has been going wrong. But I think the one that's salient here regarding the 737 MAX and the MCAS software was when they were initially piloting MCAS software. It was being piloted in planes that were still being flown by American combat-trained pilots, and they simply turned it off. Once they deployed it in more vulnerable contexts where it was harder to turn off and the pilots were less seasoned, and it was harder for the human in the loop to re-exert responsibility, that was when they had their catastrophic accidents. Okay, so how about healthcare? How about those principles applied to healthcare? This is the first FDA-approved autonomous AI device. This is IDX built by Michael Abramoff at University of Iowa. It's a retinopathy screening tool. The idea being that it's delivered at point of care. So at a pharmacy, at your primary care clinicians, you could go and look in and be screened for diabetic retinopathy. When he was going through the FDA approval process, he reached out to me because FDA had a number of ethical considerations and concerns. And we articulated both his experience as well as what we thought were important principles that augmented ALCA's work. And those were non-maleficence, that it must not do harm and that there be patient benefit, that the degree of responsibility for the tool was subject to the degree of autonomy with which it functioned, i.e., if it's supposed to be fully autonomous, then the company that built it should have responsibility for its autonomous function. If it's not, then the clinician who's supervising it and using it should be more responsible. And similarly, that it have equity at its core. These appear to be, in the statements emerging from our government, in the National Defense Authority Act, as well as this new blueprint for AI bill, appear to be the principles around which AI concerns are coalescing. And I want to pull a couple of threads within that just because I think they're important. Bias. So this is the off-cited ProPublica article from 2016 that really brought the idea of machine bias to national consciousness. This was a recidivism prediction software to enable judges to make more discerning decisions regarding recidivist likelihood in offenders that were before them, and it was spectacularly biased. And that was shown by this ProPublica article, and that raised to the fore this concern about bias moving forward. We've seen that. This is Gijbert's analysis of the Framingham study. We've seen that within healthcare, that risk factors don't apply as well to different populations when we stratify by things like risk, gender that we know about. And one of the insurmountable problems, well, insurmountable is overly pessimistic. One of the problems that we are struggling with is the reification of bias. So this was an interview study we were doing with Hopkins, and this is one of the AI designers saying, look, we do have a health, wealth, race gradient dilemma. How do you protect about inherent bias of mortality prediction? It reinforces existing inequalities. You get comfort care instead of advanced therapeutics. What's the solution to that? Does it actually help if the AI is more fair? If you're going to die soon, even from a health, wealth, race gradient inequality, aggressive high-dose chemotherapy isn't good. Okay, privacy of personal data in business arrangements. We've seen this multiple times now. This is the Royal Free Hospital breach in England. We saw it with Ascension Health. How do we protect people's privacies, but give adequate training data for these predictive analytic tools to actually perform as well as they could and deliver on the promise? This is resonant in other areas of bioethics. This is Jeff Botkin's work on the neonatal blood spot programs, in which they call out the fact that many states have neonatal blood spot programs so when a baby is born, taking the cord blood and storing it for data analysis later on. And what he calls out is the unethical outcomes from overly restrictive access to that cord blood. So a lot of research that was promised has not in fact happened because it's simply too challenging for researchers to negotiate the restrictions to get access to the samples. And that tension is what more recent research programs are negotiating. So this is the All of Us program trying to match genomic sequencing to outcomes. And that's exactly the line they're walking of how do you protect patient privacy, but get access to adequate data so that the contribution of patients agreeing to participate in this actually delivers on improvements in care. Ownership of data used to train AI tools. This is the Page AI Memorial Sloan Kettering Challenge. This isn't to call out Page AI. The CEO of it was in one of the talks that I gave and got very irate. They didn't. This is going to come up with any public-private partnership that we're encountering. But the point being that they used the data that pathologists had generated over their careers, right? So pathologists spent years learning how to interpret slides and determining what was a gold standard of this is cancer, this is not cancer. And the AI tool was trained on that. And the faculty at Sloan Kettering said two things. They said, one, this neglects the contribution of patients, and then them contributing samples to what trains this AI tool, as well as their own intellectual knowledge. Now, I spoke to my close collaborator in a lot of my work, Michelle Mello, who said she thought we had basically, by working at academic centers, abdicated our rights to the intellectual property for our work. But the patient concern is a valid one. Certainly, patients contributing to the work and clinicians contributing their discernment to the work do contribute something to the AI. It's not all of it. They didn't make the AI tool, but it's also not nothing. And we've seen this in other work we're doing with Kaiser Permanente with their suicide prediction algorithms that they want to roll out. And many of the psychiatrists within the and psychologists within the Kaiser system are saying, wait a minute, we own this tool. What's our responsibility to it? It's based on our work. Do we have to oversee it? Do we not oversee it? All of those questions. And then lastly, accountability for failings. And this is still a very challenging one. So this is old. This is when Starbucks rolled out its early what became known as the clopening software. But the point being that they came up with an algorithm to try and predict most efficient staffing models for various Starbucks. And the tension was a lot of their workforce was part-time. People in school, single parents, trying to work shifts around something else they were trying to do with their life. But the clopening software identified that it made the most sense for the person who was closing the store also to open it the next morning. So if they were closing it at midnight, they would then do back at 4 the next morning. And it wound up really disrupting people's lives in a considerable way. And they lost a lot of their workforce over it. And who was responsible was very hard to pin down. We're going to see similar issues of responsibility as we roll out AI tools, right? This is from AHRQ. We already know that alarm fatigue is a problem. I think it's very likely that we're going to begin to see AI tool fatigue, right? We're seeing an increasing number like the diabetic retinopathy screening or screening tools for hypertrophic cardiomyopathy or peripheral arterial disease, single disease screening tools that are crawling over the records to try and identify patients who are at risk and sending alerts to the primary care clinician or the point of contact clinician. And we're probably not that far away from those alerts and impacts on the workflow beginning to disrupt care or at least disrupt a bedside clinician's cognition in a significant way. And who's responsible for that disruption, what the attention span alteration is going to do to patient care, and how we mitigate that is still being worked on and being considered. Kathy O'Neill, who was a mathematician at Columbia, she's now in the private sector, called this out for this challenge out. She also called out around credit scores that a problem that we're seeing is with AI exceptionalism, which is the individual person who is the recipient of AI information, so in our case, the bedside clinician, often requires much more and much higher quality evidence to rebut an algorithmic recommendation than the evidence upon which the algorithm was based in the first place. And I think that we all have seen that in our own work with the electronic medical record alerts. Many of us just click agree now rather than fight with it because it's simply easier in our workflow, or that's not what's most important, and that's not why we logged into the record. We're just trying to provide a specific patient care, and we're having to wade through a number of alerts. Melinda Ashton, and I think this expands her work, looked at the getting rid of stupid stuff with the EHR. We're probably going to have to expand that and really empower bedside clinicians to give us feedback about how they're interacting with different algorithms, because the potential to make their lives more miserable is significant. Okay. So in many ways, calling out the principles around which AI should be tuned may be the easier problem. Much more challenging is how do you take principles once identified and pragmatically turn them into a method to identify and ideally address ethical concerns before they become consequential. And that's a lot of the work I'm doing with Michelle Mello and with Nigam. So the current state of the art, IRBs, a cadre of ethical reviews have some problems latent in them, right? The first is they simply don't scale, right? They're simply not big enough. IRBs themselves, which has come up as a possibility for handling AI, they're really designed to handle regulatory compliance. So while regulations are still being developed or principles are still being agreed upon, they're not really armed to address ethical considerations that are coming up with AI tools, particularly novel ethical considerations. It's also true that in our pluralistic multicultural society, that a cadre of self-appointed or academically appointed experts are not themselves free of bias, right? And are vulnerable to biases that can stifle research. And we've seen that very publicly play out during the last presidential administration around the NIH Ethics Fetal Stem Cell Oversight Committee that was appointed to evaluate all approved research by NIH regarding stem cells to make sure that it was ethically appropriate to do this research. And basically what happened was they stifled all of the stem cell research moving forward. And so that is problematic. Because of these challenges with ethics, many groups have turned to an idea of fairness, which is to say identifying equality of outcomes in a priori specified groups in algorithmic output. And that is something that we're going to have to address, right? We're clearly getting a lot of political pressure, this from our own state attorney general, to demonstrate that our algorithms are not biased in their outputs. There are a couple challenges with that we're going to have to address, and we are working on. Alison Callahan in Nigham's group is working with us to try and come up with ways. One is, it's not really the output of the algorithm itself that we care about. What we care about are the downstream workflow clinical outcomes from the actions undertaken from an outcome. And studying those are much more challenging. The other that I alluded to earlier is we're still using a priori specified protected classes. So this from California labor law. We don't have all of these classes represented to an adequate degree in our data. We're not really powered to detect all of these. The other is that I alluded to with the Han Chinese population or sub-Saharan Africa. We don't really have a methodology for identifying vulnerable groups within the healthcare context. While these are all vulnerable groups, it's very likely that we're going to have other groups that are not yet known to us or that we're not aware of being consequential within specific healthcare contexts. Various diagnoses, various disabilities, all coming to the fore and needing balance within how we set out the workflows. So in the ambient recording software that's being put forward, things like DAX from Microsoft that we're starting to pilot at Stanford, clearly patients who have auditory or speech difficulties or that speak different languages are at a disadvantage in the use of that tool. And how we mitigate that, we don't know yet. And how we identify vulnerable groups in novel contexts that we haven't looked at before, we're also working on. Okay. So how do we identify ethical considerations? Well, this somewhat complex slide maps out what we're thinking. On the left is, the leftmost column is FDA's software as a medical device conceptuality. So for an algorithm, really for any medical technology, there's a pipeline from conception through development, through calibration, through initial implementation, through subsequent implementations. Along that pipeline are a series of questions that designers ask, implementers ask, that aren't inherently ethical, but have ethical or values-laden components in them, which is the rightmost column. And you can imagine things like setting, sensitivity, and specificity have considerations about inclusivity and exclusivity and could have ethical consequences to their outcomes. Our work has 6 premises underlying it, which I believe, but I submit to you. There are multiple stakeholders impacted by any machine learning healthcare application tool, but that these stakeholders can be identified by examining the design and deployment context. Stakeholder groups have different values and explicit or implicit goals for any machine learning tool that should and can be ascertained. And the process of design and development involves making a series of decisions. How stakeholders make the decisions or would want these decisions made reflects their underlying values. And then this is the key one, and it draws on work by like Bray, Manders-Weitz around values in design. And the idea is that where stakeholder groups disagree or their values are at odds in resolving decisions, where they collide are where future problems are most likely to emerge. Future ethical problems and practical problems are most likely to emerge with a novel machine learning tool. Some of these may mark novel ethical concerns. Many may be resolvable by drawing on related or other earlier ethical work. So an example from outside of healthcare would be the first self-driving car fatality, where Uber engineers wanted to smooth the ride. I was having too many false positives and it was getting very juddery. And so they wanted to smooth the ride. But in post-analysis, they felt that that's entirely why it failed to identify a pedestrian walking a bicycle at night and hit the pedestrian, right? And obviously, a pedestrian stakeholder group would have wanted those sensitivities and specificities set very differently than the engineers did, because they would have had different values in answering that question. Okay, so I want to talk about a couple case studies and what we're actually seeing. So this is the very first analysis, ethical analysis we did. This is a machine learning mortality prediction tool to guide advanced care planning. So the idea being that for all patients being admitted into the adult inpatient medicine service, that this tool would identify patients who are at high risk of 3 to 12-month mortality as a way to flag them for goals of care discussions that they could have with the palliative care team. It's a great idea. We did a number of interviews, and this very serial killer diagram, detective TV show diagram, shows the challenges we've come up with we're negotiating of trying to identify the different groups. But the concentric circles deal with their proximity to the algorithm, and the various different stakeholder groups and their interrelationships are depicted by the arrows. But we identified and interviewed these different stakeholder groups regarding their goals, for understanding of the tool, goals for the tool, and projected uses and utility for the tool. And what we identified were a number of areas where they value collided. And I want to call out a couple, right? The first wound up being not particularly consequential, but was inherently interesting and got addressed early, right? Which is, what do you do when the tool appropriately identifies someone who is at high risk for near-term mortality, but it's totally inappropriate to refer them to palliative care, right? Non-accidental trauma, drug overdose, right? That was something that needed to be addressed. A second was, who should get the prediction output? Do you give it to the patient? Do you give them a mortality prediction as to what their 1-year mortality is likely to be? Do you only send it to the palliative care clinicians who then vet it and make a decision about approach? Or do you send it to the other caring clinicians, including the specialists, the oncologist, the actual bedside clinician? That was an area of uncertainty and dispute among the different clinicians and among the patients. Could the tool's output be used for non-palliative care prediction, put to non-palliative care prediction uses, right? Which is to say, could an oncologist say, well, wait a minute, this patient has a very high likelihood of near-term mortality. We shouldn't pursue aggressive chemotherapy in the patient. Was it robust enough to actually handle multiple non-palliative care goals of care discussion uses? And the third, unrelated to that, but important for all of AI tools, was there's a lot of pressure to hype what we're doing and identify this work early on, because we are in a market competition with other healthcare systems. And so was it appropriate to talk about the tool while the study was still ongoing, to post on social media? And that was an area of dispute. And this is one of the value collisions. They weren't subtle. This is one of the designers talking about their collision with hospital administration. At one point, they were asking me, can you guys predict if patients have got 24 hours or less? Because if they've got 24 hours or less, we're going to put them in observation and not admit them. And observation means they're not officially admitted. And if they die in observation, they don't count as a death. And I was like, I feel like I'm going to vomit in my mouth right now, because you're telling me you want to know they're going to die in 24 hours because you wouldn't put them in a normal inpatient bed. You'd put them in observation. Our tools were able to help guide reconfiguring and were useful. We have not done follow-up study, and we still do need to do that. But it allowed the design and the clinician implementation team to talk about examining alternate implementation strategies of who you delivered the output to, explicitly clarifying to clinicians, administration, patients that it was only evaluated for use as a goals of care guidance tool. It wasn't meant to be a general mortality prediction for all patients being admitted, and to allow an opening of discussions regarding how much to shield or not shield ongoing research from social media scrutiny and from open discussion, particularly AI implementations that fall into this gray area of QI versus research. I want to talk about the second one. This is, we did in partnership with the Pediatric Endocrine Group at Hopkins, using that IDX tool to try and expand access to children in socioeconomically depressed areas around Maryland and Baltimore who didn't have access to diabetic retinopathy screening. This is the first NIH-funded randomized controlled trial of an autonomous AI tool. And so we partnered with them and to look at ethical issues that they encountered doing this work. NIH has a number of ethical principles that they feel that all research should be valued at. This is work done by Zeke Emanuel 15 years ago, but that it have social and clinical value, be scientifically valid, fair subject selection, a favorable risk-benefit ratio, that it get independent review, informed consent, and respect for potential enrolled subjects. And our interviews with these designers and implementing clinicians demonstrated that they had tensions in a number of areas, and I want to highlight a few of them. The first is around scientific validity, and this is coming up increasingly with AI tools. What should be the gold standard? If you alter a workflow, what do you compare it to? Do you compare it to the prior existing workflow? And how about if you're using AI to expand access to a population that currently has very marginal care, if any care at all? What is the gold standard comparator that you would come up with? And that's not such an easy or straightforward question to answer. Another is, how do you randomize in vulnerable groups like that, particularly for an AI tool, right? When they did the power analyses with the statisticians, what made the most sense was to randomize at the clinic level, right? That this clinic gets AI screening, this clinic has screening as is currently practiced. But NIH was very uncomfortable with that idea, rightly so, because they raised a number of questions about, well, how do vulnerable patients who only have healthcare through this one clinic and for whom it's a significant hardship to try and go to another clinic, how do they opt out? And that's to put aside the complex discussion around how do you inform somebody about the risks and benefits of an untested AI tool in this population. Fair subject selection. So is it okay to use an AI tool to expand access to a population that currently doesn't have great care? The AI is intended to make it easier for patients to get access to care, right? It's a point of care tool, but it creates a tension, one, between reducing access and inequality, but using an AI that we know going in is biased, right? Because by definition, a population that's underrepresented in the healthcare system is going to be underrepresented in the training data. And until you start doing the studies and capturing that data, you don't know how well it's actually functioned. It's also, at its base, different care. You're creating a tiered care system. Maybe, in the best case scenario, it will wind up being better, but when you're rolling it out, you don't know. So for the patients marginalized to care, usually for socioeconomic reasons, they're getting a different care than we would get if we had retinopathy or concerns of retinopathy. And the third is, what is the social and clinical value of the tool? Increasingly, what came up in the discussions was the cost benefits, and the cost of building the tool. So let me unpack that a little bit. Calibrating better performance in one of these tools is more expensive. There's clearly a tipping point at which, particularly for a low reimbursement population, a healthcare system cannot or may not be willing to invest a considerable amount of money in a tool that's not going to have a return on investment. Or if it is, that's a dialogue that we as healthcare systems need to have. And that goes back to my running fire stations for profit analogy. Maybe we use tools for their maximum benefit, irregardless of cost. But unfortunately, in America, there is a zero-sum component that we still do have to pay for the healthcare we provide. And how we balance that is a challenge, particularly using a tool to access populations that have limited reimbursement. Secondly, and I talked about this earlier around the question of non-inferiority, what came up in a lot of the questions was, okay, if you can demonstrate that it's not inferior, do you move forward with it? How about if it's a little inferior, but you have considerable cost savings? What cost savings to what inferiority is the tipping point that you would say, let's move forward with this fiscally advantageous, but perhaps not quite as clinical outcome advantageous tool? And then lastly, obviously, is it justifiable to expand access? And this isn't unique to AI. This is any screening test, but it's going to expand with expansion tools that AI will provide. Is justifiable to expand access to screening without simultaneously ensuring improved access to specialized treatment? When somebody's in a clinical trial, an NIH-funded trial, all of the patients identified had follow-up care access. It wasn't clear, since there's a shortage of this being the universal sign for ophthalmologists. Since there was a shortage of ophthalmologists to provide screening, it wasn't clear that there would be an increase in ophthalmologists to provide treatment for diabetic retinopathy once it was introduced. And so creating, like in genomic sequencing, creating a population of worried well is not in anybody's benefit, or even worried not well who can't get access to subsequent care. Okay, so moving forward, we did gratefully, just Nigam, Michelle, Allison, and I did just get a grant from PCORI to develop our approach for identifying healthcare issues, ethical issues arising from healthcare AI. Those two cases that I told you about each took about 9 months to do. So a big part of what we're doing is trying to speed that up, right? Obviously, to be useful, ethical analyses have to be fast. They have to be useful to the many developers and designers who are building, iterating, and adapting their tools in real time. So we would like to get it down to a month-long process, and that's what this vision involves. Doing a series of interviews with clinicians, developing a cadre of patients who are engaged in care. One of the challenges we've had with patient interviews is that because knowledge about AI is actually quite low in the general population, that when we interview patients, we tell them about AI and then we ask them a series of questions, and often what we get back is just the information we just provided. So building, like in clinical medical ethics, that there are often patient representatives who are part of the clinical ethics team who have developed an acumen and a knowledge and experience around clinical medical ethics. We would like to develop a similar group around AI healthcare ethics. Also an oversight to call out novel concerns and discuss their implications, and to deliver this back in a useful, easy to digest, non-overly IRB'd way to designers and clinicians who are implementing these tools. These are the challenges. Can we nail the 1 month cycle? Can we cultivate a coaching cycle, a coaching culture where we actually work with teams and help them negotiate ethical issues, but without being an impediment to their ability to develop consequential tools? And how do we develop scalability and exportability? How do we make it usable to other healthcare systems that aren't as resourced as we are, that are more rural, that don't have ethicists, bioinformaticists, AI, computer science designers available to them, but still need to evaluate the tools they're considering purchasing or deploying? How do we do that? And a forthcoming playbook. So a playbook, the idea being, like medical ethics has developed categories of ethical problems that come up in clinical care, futility. We would like to identify similar categories of problems that come up with AI tools to make more efficient the ability to identify likely challenges that people are going to encounter with a type of tool. Okay. Obviously, as I noted earlier, but want to call out, I'm not doing this work alone. There are a number of funders and a number of close colleagues and collaborators who I would like to thank, all of the people in this list. So thank you for that whirlwind and letting me talk about the work that we're doing. I'm grateful to get a chance to speak with you about it. And obviously, I'm eager for any questions and discussion.
Well, great. Well, thank you so much for that really fascinating talk. It's highlighting a lot of the challenges that we're facing. If people have questions, there's some in the chat already. If you have questions, please put them in the Q&A and we'll get started. One of the things at the highest level, one of the things that I think is a huge opportunity for us at Stanford is to kind of tackle some of these issues. I mean, if we can't figure this out, who else in the country can figure it out? So I really applaud you for doing this work. One of the things you and I talked about this right beforehand, but one of the big challenges you talked about, non-inferiority in general, is how the current state is not great. So is the bar the best possible, like the optimal outcome, or is the bar, as you were talking about in Baltimore, is the bar, can I do better? And I think we're running into that in lots of circumstances where I'm trying to plug a gap with a technology. So how have you guys, or where are we on that line?
Oh God, that's a great question. And I think it weaves a lot of the challenges that we're facing right now. So the easiest answer is we do have ways to study outcomes. We could look at the overall long-term clinical outcomes as we have done with clinical trials. There are some adaptations that are going to need to be made for randomized controlled trials of AI tools, but that's a nuance and that's solvable. But the biggest problem is that they're quite slow. to do. They take longer period of time to look at outcomes than the speed with which AI tools are currently being implemented and adapted. And that largely has to do with financial pressures. The other is what I was alluding to earlier, which is the challenges of setting up AI research and the scrutiny of IRB and negotiating that in this increasingly blurring spectrum between IRB, what is research, what is QI, and what is private-public partnerships. Challenges to ethical scrutiny encourages circumvention, and it encourages people to go around and go outside. And we're seeing that increasingly. We're seeing more and more trials of AI tools being conducted internationally. And that was one of the big challenges that Michael Abramoff fought when once he got FDA approval, Google came into that space very aggressively, and they were able to do a much bigger series of trials internationally than he was able to do domestically, following all of the ethical constraints of IRBs. They were able to do faster. And so that's not an answer for you, but a highlight of some of the challenges we have to address.
Yeah, that kind of gets to the scalability issue. As you've that AI mortality prediction algorithm, you did a really amazing job with all those interviews. But, if you look at that, that's been around for about 4 or 5 years. There have probably been 1,000 other algorithms developed here on campus. Like any two computer science students can spend a weekend, and come up with something pretty good. So, how do we stay in front of this when it really is a scale issue?
So it's a great question. And that's why I led with the workflow stuff, because I think, as my colleague Michelle Mello would say, it still looks like it's a buyer's market. The bottleneck doesn't appear to be generating the algorithm. And I think Nigham's work is showing this increasingly. The challenge we're seeing is that building a workflow where the AI tool actually solves a real clinical problem that has valence to clinicians and patients, and altering the workflow in an intelligent way to optimize use of a tool that has been well tailored to that context is the ways in which we're going to wind up having to work with AI. So just a couple of students coming up with something on a weekend because they Googled a problem is unlikely to be the best use tool. What we're going to have are changing hybrid workflows where we're having to work with and around AI tools to ideally optimize care or make care more efficient to treat the many patients that we are having to see. I know you're privy to these conversations too, but many of the discussion about our new hospital is that it's already too small for the patients that we need to absorb into our spectrum. And so coming up with ways to pass patients through more efficiently, but also access patients outside the hospital are stated goals with our AI objectives.
Yeah. So Steve Goodman in epidemiology has a question about, the misinterpretation of many of the differences in prediction as causal. And causal inference. And, so where do we come down on the value of these predictions and what they really mean?
Yeah, I mean, so Steve, obviously I defer to your expertise in epidemiology and this work. It's a great question. And I don't have an easy answer that I can give here. I think that we need some more rigorous testing about what we buy, what we don't buy. I think that what is challenging in the work we're doing is, in fact, there are a number of very clinically consequential but not clinically facing or clinically vetted AI tools that are already changing the way we deliver care. Allocation of OR space, allocation of material supplies, patient allocation and rooming that are going to be very significant that will never be tested in the way that you're talking about. And that is going to impact care in a significant way.
All right. Steve Ash is a kind of a different question. At some level, we have a standard algorithm, and then you're supposed to tune it for your population. There's this idea of this technology can evolve. So how do we think about the ethical evaluations as you go forward? If at the most extreme, if I develop an algorithm at the Mayo Clinic on the white patients in Rochester, Minnesota, can I tune that to inner city LA?
Right. That's a great question. So the degree to which algorithms are context specific is still unknown, right? It's a problem. The other problem that you're calling out that I think is spectacularly valuable is the locked versus continuously learning tool, right? The promise is that it can continue to learn from data. The downside is once it's been safety tested and assured in a locked mode, once you allow it to drift, it has the potential to become unsafe and to change the associations that it's making. And who is accountable for that scrutiny and how we provide that scrutiny, we have to answer. And I think, I mean, I don't want to be flip, but obviously if you get the wrong cat video, the stakes are a lot lower than talking about moving these tools into healthcare. And so how we balance speed versus making sure we were actually safe at avoiding consequential problems is exactly what we're trying to work on.
Yeah, it's actually a related kind of question to that. The algorithm's only as good as the data. And the quality of a lot of our data are really poor. Um, you know, I it's hard to make heads or tails out of our charts. Uh, so how do we know anything about the quality of the data? And, patient comes in from the emergency room, this happened during COVID. Like, for 3 days we wouldn't have any results, so we couldn't call them COVID positive.
Right.
And, for the first couple of months, that was really a hard, a really difficult circumstance.
Yeah, absolutely. This is the challenge with meta-analyses all the time is how do you take a bunch of crummy studies and make them look spectacular? It's a problem, right? And another problem is as we become a multidisciplinary field and we're having to cross boundaries to work with computer scientists, we're having to educate them that when you look at mortality data, what we called cancer 100 years ago may not in fact be what we would call cancer now because the gold standards of diagnosis have totally changed. And that's probably true in much more small and nuanced ways for data moving forward. And pandemics, punctuated equilibrium are obviously going to be a considerable challenge.
We're getting towards the top of the hour, but a question that's probably at the top of mind for lots of people. Um, is this going to make my life as a clinician better? Uh, am I going to have to see more patients because of AI? Is it going to make my job easier? Where does that come into the framework?
Um, God, I mean, certainly if the EHR is any model, it did both. And there was a lot of stub toes before it began to be better. The hope is that AI tools that are being considered are being considered in ways that will help with the stupid work that clinicians have to do. So the generative idea behind this Dragon dictation assisted software would be to ambiently record the clinician patient interaction. And I think there's a lot of enthusiasm for that because then a large language model could turn it into a note and hopefully make people's lives easier. But I can't say that there won't be frustrations, particularly around multiple AI tools interacting and colliding with each other, and how we're going to prioritize which tools get used and how we're going to prune down the distraction on people needs to be thoughtfully done. We may be something of a testing lab, being as vanguard as we are as an institution, we may be something of a testing lab for America. And so there is an effort to try and have talks like mine be happening with increasing frequency to get everybody educated so that all of the bedside clinicians can weigh in on what they see happening and that we have mechanisms for people to weigh in and give feedback about, hey, this thing you thought was wonderful is really not wonderful because, and to take that feedback seriously.
Yeah, well, actually, that's a great observation. That one AI prediction algorithm, I was one of the attendings on hospital medicine when that was rolling out. And, it was a real challenge. A patient's can stay in the hospital for a day or two and they're seeing other providers on the outpatient side. Is it the hospitalist medicine's job to make that referral to palliative care, or should it be the primary care doc who's got an established relationship with that person? So I think they're really challenging. I really appreciate you doing all this work and bringing, this perspective to how do we develop this technology? Can we stay in front of it? Can we stay concurrent with it? Can we not fall too far behind our friends down the street that are putting $10 billion, into it?
Yeah.
So thank you very much. Thanks everyone for joining us this morning. We could go on and on, as Errol likes to say. This is a really fascinating discussion. So I hopefully can have the opportunity to bring you back again in the future.
Well, thanks so much for having me. It was really fun.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.